So today we're going to be talking about our heart failure stages and basically how we classify and categorize heart failure. And again, kind of how those therapies sync up that we might start a patient on and what we should be thinking about at each stage as the patient may progress or develop new symptoms. So the first one that we're going to talk about, is the one everyone's probably the most familiar with, that comes more with our symptoms, which if you can guess what that is. So one, I'm just going to label it like that as we go through it, is our New York Heart Class Association. So it's going to be our New York Heart Association classes that we talk about. And this is primarily, like I said, more of kind of is symptoms. So how well the patient's being able to do different things of that nature. And so these are numbered by Roman numerals, and so it's class 1 through class 4 that we have. And this is flexible and fluid, and patients can move back and forth all around. So just to remember that, I'm going to say it is dynamic. So patients can move all around. And so let's start with our class 1. So these are going to be our patients pretty much with no symptoms, no limitations, or very minimal. So these patients are going to have no limits. They're going to do their daily routine, activities of daily living, everything like that. And then we move into our 2 patients. These are going to be our patients that are a little more limited but can still do daily activities with maybe just a little bit of shortness of breath. So we can say like can do activities of daily living, so that's what the ADL stands for, is activities of daily living, but may get short of breath, but have this shortness of breath. Then we have our class 3 patients. And these patients, however, kind of fall, they're really close to 2, hard to distinguish, but they're going to have more shortness of breath, but can still do some activities of daily living. So they're going to have more shortness of breath, but can still have some of these activities of daily living. And then we have our final class of patients that we hope no patients end up getting to, but these are those that are like pretty much bedbound. Can't really even do their activities of daily living. So they're going to be kind of staying wherever they are. So one way I kind of like to remember this as an easy way to do that is actually if we actually have our little patient here. So our patient that's in the house, so in the house, and they are basically staying there pretty much bedbound, right? So they're got a little chair here. They can't move. They can't get out of their house. Then somebody with shortness of breath may be able not to necessarily go all the way and get their mail, but they could at least get to like the front door before having to stop and take a break. So if we have our little glass here, we could have the little patient would be kind of just get to the front door, but still in their house. Now, our class 2 patient that would have these symptoms would be somebody that can get out of their house, so we have their little house here, and is trying to get to the mailbox, and so we got a little mailbox, but he may stop like halfway before he gets short of breath. Our class 1 patient would be able to victoriously make it to his mailbox without any symptoms, get the mail, and see what today's ads are. So patients can, based on how well we treat them, diurese them, different things like that, can move all along these different stages. Now there's another stage that we look at that we call, instead of classes, we call them mainly stages, and that is our American Heart Association stages. So we'll abbreviate that as AHA and stages. So these are actually a little different than our symptoms and classifying them. This is something that is kind of a prolonged and goes along, progresses for the patient. So it's not dynamic. This is only a progression of stages. So it goes all the way through, and unlike our New York Heart Association classes, it's not Roman numerals, but it's actually letters, and it's A through D. And this is a lot about how the guidelines nowadays actually pick and choose when to start therapies and things like that. So let's start with A. Start at the beginning with A, and these are going to be our patients that are actually at risk. So these are our patients with hypertension, dyslipidemia, maybe even diabetes. Anything that could contribute to heart failure would fall under our Class A patients. And for treatment for those patients, we're actually going to start doing preventative therapies. So we have lifestyle, so we get lifestyle modifications. We're going to treat with that right away. And so that would be things like diet, low salt, trying to manage, watch what we eat for glucose control, all those things. And then we're also going to probably start an ACE inhibitor or an ARB, or theoretically an ARNI falls into this class too. Anything to help manage those that would be at risk. And then we're going to continue these all throughout the next stages. So once they're on here, starting in one stage, they continue and keep going. So the next stage that a patient would progress to would actually be stage B then. And so these are going to be our patients that kind of start to develop structural heart disease. So this is going to be like minimal disease. So our minimal disease patients. So when these patients this far and they have structural changes, especially the reduced ejection fraction is what these therapies relate to, is heart failure with reduced ejection fraction. Then they've got lifestyle, they've got an ACE inhibitor, ARB on board. The next step then is to beta block them and decrease the cardiac output and the workload on the heart. So we're going to add, and I'm just going to abbreviate it as BB, a beta blocker on board at this stage. Because they've already progressed and started to develop heart failure, so we're going to add and do something else on top of their lifestyle in ACE inhibitor therapy. The next stage is stage C. And so for ease of purposes, this is more of a moderate disease. And technically, so I'm just going to abbreviate it for space of mod and say disease. And technically by the guidelines, these come with symptoms as well. Again, progressing from minimal shortness of breath to more to bedbound. But this really focuses on the disease, so that's all I'm going to kind of cover on the board. So we've already got their lifestyle, ACE inhibitor, beta blocker. What else can we add on that's been proven effective to help with morbidity and mortality? So that would be our things like we could add our potassium-sparing diuretics. So that would be like our aldosterone, if you think about that. And the other one in that class is a eplerenone. Not as commonly used, but also good to know. Other things we can add on, depending on the patient's race and things like that. For our African American population, a really good combination to use in conjunction is our hydralazine and nitrates. So that combination has been shown very effective, especially in our African American population, when added on in addition to our beta blocker and ACE inhibitor therapy. So another option that we can use that doesn't necessarily reduce morbidity or mortality, but does reduce hospitalizations for our patients with reduced ejection heart failure is going to be adding on digoxin next, which I'll abbreviate as a DIG. And then there's another important therapy that actually might get added on maybe when they're in stage B, But really when they're experiencing symptoms and have moderate diseases in stage C, we put all patients on, would be to help with our fluid status and symptom management. And so what do you think that might be? We're going to help manage fluid, so we're going to be able to diurese the patient and prevent that volume up. So that's going to be our things like our loop diuretics. So our loops. And then depending on how the patient progresses and different things like that, we could add on other things as well, such as metolazone or other sequential blockades that might need to come on. So the last stage that we could encounter would be stage D. And so those are going to be our advanced patients with severe, very severe disease. We'll do this. So unfortunately, when our patients really get to this stage D, they're having very severe symptoms. Their heart is very sick and has had a lot of structural changes. There just isn't a lot left pharmacologically that we can do. We might start the patient on some inotropes, but that's not necessarily going to fix them or help them along the way. It's going to be more of a palliative measure. So we have to consider advanced therapies. So other non-pharm therapies like our LVADs or even like end-of-life care. So our other therapies that we would have to consider when we get to this, or transplant even, which I'll abbreviate, or having those hard discussions with the patients. But this is just another quick review about patients and therapies we would choose when we classify them by our American Heart Association stages, and specifically for our patients, like I said to begin with, these are all our heart failure with reduced ejection fraction therapies.